What is wrong with these films? When I ask what is wrong with the film, there's only one answer: radiation protection, right? Normally, you should not be able to see the black corner of the film. They should be collimated. And in this patient, there is no reason why it couldn't have been collimated. He could not have cut. For example, this part may be been collimated, this part may have been collimated. It's a good thing that he has not collimated something here, and we'll come down to that. But normally, we have very poor sense of radiation protection. I mean, that's a sense of caring for the patients, right? You do this in the US, you go to court. And unless you people keep telling the technologists that don't do it, don't do it, don't do it, don't do it, they don't care. Many of them are not even qualified. They don't know the spelling of radiation protection. So all this gada mujuri comes on the resident who sees every single firm. So you may say, oh, technician down, my kya bolu? In our country, it doesn't work that way, right? If this was your baby and this has been exposed like that, you will sue the hospital. Don't take anything for granted. Anybody throwing kachra on the road, catch him and beat him up. So if your generation doesn't change the way of living now, we will be the same country. Made in India. Nonsense. Yeah? So the first thing here, you should be aware that this is bad technique, right? Bad medicine. You cannot expose the whole world just because you want to take, your bad technique, or you're not even aware that there is something called radiation protection. Then I'm going to ask you a little question after that. So who's going to talk about this? Then I say, who's going to talk about this? Somebody, for God's sake, start talking. You're what, one more baka, what? Okay, it's your turn. Lead by example. You know what's meant by lead by example? What does it mean, lead by example? Why are you becoming an example? Because you are an assistant chief resident made just now. So you are a cut above them. So if you have responsibility, you have to lead by example. Your teachers have to lead by example. Don't tell you all what to do, but do something which you will automatically follow. You understand? Lead by example. Google and see exactly what it means. Yeah? Okay.
A 40-year-old gentleman with frontal and oblique projection involving the including the left shoulder joint and left humerus.
What is the actual legend? Say frontal, AP and lateral, no? AP and lateral has not been done. These are small things which are important. Why do you say it's oblique? Which is frontal, which is lateral, oblique? Why do you say it's frontal?
Both the epicondyles are seen lateral and medial. So
which epicondyle? So the lower end of the humerus is in AP view, more or less AP view. It's still not perfectly AP view, right? Which is this view. So neither is a lateral view. This is, as you said, oblique view, right? So this is more likely, I'm sorry, I'll just silence it. This is called leading by example. My phone is going tim, tim, tim. I cannot expect your phone to be on silent. Yeah? Okay. So the moment you have a frontal and a lateral view of what has been asked for?
Shoulder joint including the left humerus.
So can you get a frontal and lateral view of the shoulder joint including the humerus in lateral? So why is it not possible? Can you get an AP view of both of the humerus and the shoulder joint in one picture? Very good. And lateral view? Generally, it's not possible. You should do some Bharatanatyam, it may be possible. So you cannot normally have the shoulder view. So I'm going to ask you next time. Actually, I want you to do this. whenever you have a patient with shoulder, I mean, you'll get tons of patients with shoulder, tell the radiographer to call you and I want you to take what is called as a lateral view of the shoulder joint. Write down, you'll forget.
As per books, as what they take normally.
No. What is the right way? If they're walking upside down, it doesn't mean you walk upside down. The reason I'm asking you is that it's something that people make mistakes all the time. I want you to take lateral view of the shoulder joint, not of the humerus, not of the scapula, but of the shoulder joint. And I want to see that X-ray. Yeah. So this is wishy-washy, somewhere in between. So what does it tell you? Suppose there's a technician who knows how to take a lateral view and you get an oblique view. What does it tell you?
Patient might be in pain because of which.
Very good. So the patient may be in pain or there may be stiffness that does not allow you to position the shoulder in a proper lateral view. Okay. So you started off by saying that these are frontal. I want you to change that order of that sentence, right? You don't start with 27-year-old gentleman or whatever. What is the age?
40.
40-year-old man. So you start by saying these are frontal and oblique views of the shoulder, left shoulder with arm of a 47-year-old man. So you cannot have a 47-year-old man with X-ray done, which is right but not a pleasant way of putting things. Yeah. Okay.
Frontal and oblique radiograph of left shoulder joint involving forearm.
Not involving the.
Including the arm.
Yeah.
Including the arm of a 40-year-old gentleman.
So many people, even in Kokila Bend, use the word gentleman. That's wrong English. Gentleman has a particular meaning, so you simply say man. Yeah.
40-year-old man. We can see.
Okay, now what? So you have this phone. Call any ward boy you have. Call any ward boy you have. Call. You have to believe this. You have to see that it's happening.
So have you read Sir's blog on the autopsy? Have you? Go ahead. We'll put it on the group.
You didn't know why it's so difficult to find.
It's like talking with the confused.
पुढे या ना तुम्ही चालेल ते जॉब वगैरे चालेल तुम्ही मराठी बोलता ना मराठी हिंदी मराठी पुढे या तुम्हाला प्रश्न विचारतो तुम्ही तुमचा एक्झाम आहे आता हा एक्सरे मध्ये ना तुम्हाला खराब काय आहे कुठे वाटतं तुम्हाला पुढे या ना तुम्ही दाखता कशाला एक उंगली घ्या आणि दाखवा मला कुठे तुम्हाला वाटतं की रॉंग आहे त्या पेशंटचा तुमचं चूक झाला तर काय फरक होत नाही असं तुम्हाला मनात काय येतं ना ते सांगा तुम्ही ह्या मुलासारखं दिवसभर घेऊ नका लवकर सांगा तुम्ही हे घ्या आणि मला दाखव चला लवकर किती वर्षापासून आहे तुम्ही या डिपार्टमेंटला तरी सुद्धा दाखवतो हा कुठे काय दाखवतो तुम्ही हा ते सगळं वाटतं ना व्हेरी गुड बरोबर आहे जावा तुम्हाला एमडी देतो मी का थँक्यू I'm doing this stupid thing for a purpose. You will never forget this now. That you have to learn to ignore the obvious. I'm not saying you don't describe it, but when you have a lesion in the shoulder, it matters not what the lesion is. Usually a part of other bones is seen, and most important for you all, a part of the chest is seen. So non-collimating here is good. I told you, no, I'll come to that. Why not collimating is good? Because you can see a part of the shoulder. I'm sorry, part of the chest. But I would have not wanted to see all of this. So you can describe this as much as you want, right? And maybe you should describe this first, but you should never forget, at least at the Tata Memorial Hospital and anywhere else in the world, that if a part of the chest is seen with something like this, or even without that, you have to look at the chest that is seen. It's optional, extra, free. It's like Amazon. Buy one, take two. You got it? That's important. If there is a fractured patient with multiple polytrauma and there is a huge fracture of the humerus, and you write all 10 lines on the fracture of the humerus, and there is a pneumothorax humerus, the humeral fracture doesn't matter much, but the pneumothorax is what may kill the patient actually. So looking at everything in the chest and sometimes in the abdomen in a shoulder x-ray is paramount. It is basic, it is absolutely fundamental. Many of you will do it, and that illustrates a very basic point. Look at everything that ought to be seen, which is what many referring physicians don't. They know that this patient has a whatever in the shoulder, and if they are not trained properly, they look at that and sort of forget it. This happens oftentimes with trauma. The patient comes with, for example, a fracture of the humerus, a wrist drop, and sort of early gangrene. They are concentrating on blood vessels. They are looking at the fracture. They are looking at the radial artery. I'm sorry, that would be the, what would that be? Got radial artery, yeah, radial artery. And they also look at if something has happened to the, what is this now? Extensor? Yeah, where? Usually injured where? What is that syndrome called? The day after syndrome. Yeah, okay. So they are concentrating on that, and they would probably not pick up a fracture of the neck of the first rib on the ipsilateral side. Yeah, why is that fracture important? No. Yeah, neck of the first rib. It's a fracture that you cannot pick up easily, but if there is one, what vessel now? Yeah, subclavian. So injuries to the subclavian artery are uncommon but well known associated with fracture of the neck of the first rib. The point I'm making is that these are important. The ability to look at every single finding without getting biased by the obvious, right, is important. This you have to describe. In an exam, you cannot start saying this. The examiner may not know that you have to look at that. Yeah. So you describe it, but never ever forget this. In fact, I've finished looking at this side. I look for pneumothorax, I look for metastasis, I look for mediastinal shift, etc. Fracture of the clavicle, sometimes missed when you're looking at fracture of the humerus. Okay, now we come down to the main discussion. Sorry? No, wait. So you have frontal and lateral views of the whatever of a, no, that's okay, it's 40-year-old. That again Akash can say. Of a, yeah, mature skeleton. You understand what's mature skeleton? You heard me talk about that? Mature skeleton. Okay. Means what? Yeah, epiphyseal fuse. Why should you talk about that? 27-year-old, everybody understands it's a mature skeleton. By saying that it's a mature skeleton, you are reinforcing yourself that I have to look for mature versus immature skeleton. Otherwise, 27-year-old can be a matter of routine. I'm looking at everything and I'm saying 27-year-old. Yeah, why is it important? Mature versus immature? Bone diseases? We're talking of tumors, right? In tumor diagnosis, the actual histological diagnosis sometimes is easier on X-rays than on MR than on pathology. So you can say that bone tumors follow a certain pattern depending upon whether the skeleton is mature or immature. What you know, you have to articulate properly in the exam. If you don't articulate it here, you will not be able to articulate it in the exam. Worst scenario, you will make a big mistake, look like a fool, everybody will laugh. It's better that it happens here rather than in an exam. So I don't want any of you to hesitate to say what comes to your mind. Now you're hesitating, right? You knew the answer. Why hesitate? So in 2 years or whatever you are here with me, you should be very confident of talking. Whether it is right or not, it is irrelevant because you cannot be right every single time. I promise you, you take an exam of me showing 10 cases, I will fail. It depends on which side you are on. I happen to be on this side. It doesn't mean that I know everything. It doesn't mean that you cannot make mistakes. You have to have that confidence. In 2 years, all of you will be consultants, right? What do you mean? Yeah, you will be consultants. Of a mature skeleton, which shows, now it comes to this, which shows, and there's a big pause. The clock has struck 9, 10, 11, 12, and the pause is going on.
Shows multiple well-defined oval to round height.
So you have to have a size for everything. For example, if we have to describe you, right, and don't mind my saying that, I'll describe you as short, right? So some way we start with short, dark, fair, whatever. So a human being is, maybe you can even describe in terms of height. So whatever is in radiology, because you people are so used to doing CTs and MR now, your language also is wrong in terms of plain films. And you have forgotten that you can eyeball and say approximate size. Yeah, so you started well by showing that there are
multiple well-defined sclerotic lesions.
Very good, yeah. You didn't say hyperdense. Now other people say hyperdense. And then I feel like pulling my hair or your hair.
Oval to round sclerotic lesions of average size of 2 centimeters are seen around the left shoulder joint. Left shoulder also in the proximal humeral area, and left shoulder joint space could not be clearly seen.
So this is something you should not mind again, right? People have habits. I have habits which may be irritating to you. So some people like you shake during the exam. You're sitting like this, you're boom, 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 boom. You're not even aware of it. Yeah. So some people wear glasses like this and go to the exam. These are something that irritate the examiner, right? Please do not mind. And it's very difficult for you to control. You will normally do dum 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 dum. Yeah, sit straight. Don't make too much movements with the hand. Yeah. Don't take a pencil and start pointing unless you are asked to point. These are small things which irritate an examiner. I mean, it's subconscious. Yeah. Carry on from there. So what I do, if I don't know what the hell is going on, in the region of the shoulder joint, around the region of the shoulder joint. What am I saying? As seen on the X-ray, it is in the region of the shoulder joint. I have no idea where it is. It may be inside the joint, it may be on the skin, but I'm saying that it, and also the person who's looking, who's imagining will know that it is around the shoulder joint. So instead of saying in the shoulder joint, you can say region of the shoulder joint. For example, if there is a nasogastric tube in a pull-through surgery, right? So, and the tube is in the region of in the fundus, but the fundus is high up there, you will say in the region of the fundus of the stomach, given normal anatomy. If you don't know, a surgery has been performed. So how you use words is also important. Move forward, yeah.
Around the shoulder joint.
Now, the moment you say, once you say around the shoulder joint, You are saying that it is extra-articular. You think it's extra-articular? Say so.
Around the region of shoulder joint and extra articular location.
Very good. So you made up your mind, right? You are committing yourself that it is extra-articular. Okay. Don't be afraid. It doesn't matter. You may be right or wrong.
Most of these lesions appear to be cortical based, and the left
Which
shoulder
cortex you
joint-
mean? Which cortex?
See, these lesions appear like cortical.
Look at both views. Now why are you looking at one view? This is miles away from the cortex, right? So where is this actually? If you were to do a CT scan and take an axial section, what will you find? So there is a cortex of the humeral head or the neck, and then there is a medulla. In relation to that, where would these be?
Outside the cortex.
So it is around that area. It may be inside, it may be outside. Okay.
The left shoulder joint space
Could not be is past. You are living in the present, no?
is not seen clearly.
Okay. This is another good word to use. He is not seen clearly. To me, it's not seen clearly, but you use passive tense and say that it's not seen clearly. So what else have you to describe? Yeah.
Rest of the bones appear normal.
What is this? What is this? No, you cannot, as a matter of routine, say the rest of the bone looks normal. So when you don't know what's going on, yeah, just mag it and see what's going on. Mag this one, yeah. Is this normal trabecular pattern? You think so? What is this?
But on this view, it looks like this.
Yeah, one view it may look like this, but the view where it's seen better is the view that you look at, right? If there is an AP view, no fracture is seen. Lateral view, the fracture is seen. You can't say AP view, there is no fracture.
Some reason arch type of calcifications are seen.
Sorry?
Medullary region.
What is the word you want to use?
The chondroid type.
Okay, whatever, yes. Okay, some calcification is seen in the what looks like the medullary cavity, right? Both views it looks the same. Okay, move forward.
Cavity of the lower end of.
Now this one is something which is optional extra. We just happen to notice it. But if you demag, I should not have actually pointed this out and let you talk, right? So you have this lesion. You said that the rest of the bone appears normal. That's why I asked you about this. And then what more description?
The acromioclavicular joint appears normal. The visualized
Wait a
left
minute.
lung
Wait a minute.
normal.
You appear to be 100 years old. You appear to be 25 years old. You are 25 to 20 to 25 years. Don't use the word appear to be unless it is really appear to be. Is it normal?
It is normal.
Yeah, it is normal. Don't use appear to be unnecessarily. Radiology reports cannot be weather reports.
Visualized left lung field.
The possibility or the probability of this cannot confidently be done. That's from a surgical resident. So the acromioclavicular joint is normal. So around the shoulder joint, what else will you describe? Normally you describe the subacromial space, but here it's irrelevant, right? Okay, what else?
Mild soft tissue is seen.
So you should have started with that, right? So soft tissues, fat planes, cortex, medulla, and before all this, the age of the patient. Whether it is arthritis or especially with bone tumor, you have to start from somewhere. You cannot jump at what is obviously abnormal. You see that the soft tissues of the arm are also wasted. So it, appear to be wasted. You can say that it appears to be wasted. Yeah, so he may be constitutionally thin, but I feel that he is wasted. Why am I saying it's wasted?
Could be disuse atrophy of the left upper limb.
Yeah, but why am I saying it's wasted? How do you say wasting on MR? So do you see fat here? No? What is all this black stuff?
This is on subacute fat. The
No, what is that?
muscle
Yeah.
should-
What's all this? What this one? The subcutaneous fat is this, right? And what is this black stuff here? So if you do an MR, you'll find that there is a lot of fat here. And the arm looks so much very thin. There is no deltoid bulge at all. So I have no doubt this arm is wasted. So it tells you that it is either a painful condition and or a painful condition and or don't do mundi loving like that. Subconscious. And or yeah, very good. So it's either a painful condition and or a chronic condition. And the fact that they could not obtain both views properly, maybe it was associated with severe pain. Yeah, okay. So we are going all over the place here because I want to cover fundamental issues here. So you start with age of the patient, mature or immature. You look at the sex of the patient, or better still, the gender of the patient, because some things happen in girls and something happen in boys. You subconsciously notice about the amount of wasting that is there. You describe the lesion, look for other lesions elsewhere on the film. So, elsewhere on the film.
No lesion is seen.
No lesion is seen in the humerus.
Rest of the bones.
Yeah, so what have you got against the lung? That's what I'm trying to say, that you have to look at the lungs every single time at the Tata Memorial Hospital or on Rasta if you have your clinic on the Rasta. So you have to say that the
Left lung field is clear.
you don't see the full lung, right? Or do you see the full lung? Yeah, you can see. So you can say that there is no abnormality seen in the lung or the left hemithorax or whatever. Look at other bones. So you look at the humerus, that's not enough. You have to look at every rib, and looking at ribs is not easy. So this is not something you report in 30 seconds, right? This takes 5 minutes to look carefully, because if this is the only lesion, there is something about it. If there are multiple lesions, there is something about it. This may not be multiple, but there are lesions which can be multiple, and your whole diagnostic workup changes completely. Now, when you do a PET scan, you'll eventually pick it up. That doesn't mean that you're allowed to miss this on the plain film. Okay, now we come to the differential diagnosis. Mature skeleton, multiple faceted. I would like you to use the word faceted. You understand what is faceting? Facets. So if you have two lesions touching each other and they're moving with each other, they automatically adjust to each other. That means one is like this, the other is like this, one is like that, the other is like that. That means they're complementary. You understand facet joints? You've seen facet joints. So one inferior facet is like this, one superior facet is like this. They adjust to each other. Gallstones typically are faceted because they are partners. They have to be inside the gallbladder and they adjust to themselves. So one sort of carpal bones are faceted. So when it means that they are faceted, I'm not sure it's really faceted, but okay, I'll take back that word. It is not faceted. It's like a amorphous, well-defined calcification, multiple, are in the region of the shoulder joint. Most likely diagnosis. Okay, give me any differential diagnosis. How do you approach the diagnosis here? What?
Calcinosis or sessile osteochondrosis.
No, you have to have logic. It can be this, it can be that, doesn't make sense. You may be right, but that's not a way of describing it. So you start by saying that this is a mature skeleton. I see dense calcific lesions. They are not like bone where you have actual cortex and medulla. Some of them may actually have bone structure, but most of it is like calcification. They are not in the bone. They are not in the bone. They are around the bone. They are in the region of a joint. So if I told you multiple calcific shadows around in the region of the joint, what do you think of? Sorry? Synovial? Yeah, synovial osteochondromatosis, synovial chondromatosis, whatever. That according to me is the only diagnosis here. Nothing else fits into this. And sometimes synovial osteochondromatosis looks all over the place, but actually is in the joint. Some of this, as you said, tumoral calcinosis can be around, but tumoral calcinosis is sheet-like calcification, not calcification like this. So this, according to me, is the only diagnosis here, given that there are no metastases. So you can theoretically have any bone-forming tumor. So I want to think logically. This is new bone formation, right? So new bone formation, if it is benign, you have osteomas, osteochondromas, and what else? Osteomas and osteoblastomas. 4 new bone forming benign condition. Now this doesn't fit into a bone forming bone tumor because this is around the joint and the rules of the game are different. So you make a gestalt diagnosis. I have seen osteochondromatosis like this, so this can be synovial osteochondromatosis. Tumoral calcinosis looks like sheets, and therefore this is not sheet. Can this be a osteogenic sarcoma? So you have to. So what we have done so far, we have looked at this lesion, but we have not looked at that metaphysis carefully. Why is this not an osteogenic sarcoma? For one, it doesn't look like osteogenic sarcoma. Any other?
So the associated soft tissue is not very large.
Yeah, first of all, there is no soft tissue swelling. This is mature skeleton. It may be metaphyseal, but it is around the medulla is normal. So, I mean, there is no stretch of imagination that you can say that this is a osteogenic sarcoma. So this does not follow the normal rules of what we do when we look at bone tumors. So this aren't many. Right? Sometimes you cannot follow the rules for tumors which are around. Anything else can be like this. What about pigmented glenodular synovitis? So when you have tumors in the joint, they can cross the joint. I told you that normally tumors don't cross the joint. The exception to that are aneurysmal bone cysts, especially in the spine. It can occur on both sides, and anything that arises from the joint can affect bone on either side of the joint. I'm sorry, bone on both sides of the joint. Anyone has any other thoughts? Don't keep quiet. Yeah, anyone?
Normal calcification of TV minor.
Sorry?
Normal calcification of TV minor.
No, not possible at all. This is all over the place. Teres minor calcification, first of all, is uncommon de novo by itself. Teres minor is attached to where? Are you sure? Besides, it cannot be on the convexity side. It cannot be on the convexity. It's all here. So this is not dystrophic muscle calcification that you see in degenerated short joint. Yeah. Any other thoughts before I ask Akshay? Any other thoughts? Akshay, what do you think?
Yeah, that's what it is.
It is synovial osteochondromatosis. Now you should read about synovial osteochondromatosis, the pathophysiology of synovial osteochondromatosis. Yeah, it's quite simply fascinating. A small segment of calcification. It is something that commonly happens in the knee joint. You guys have to get fascinated by what you see. MD is incidental. Do you know that in complex congenital heart diseases, the incidence of cervical ribs is unusually high? So I went to the Department of Anatomy at KEM, where I know I have a teacher who is now a friend who wrote a textbook on embryology. Yeah, so I asked her, what the hell, what's going on here? And she said, it's well known, they're divided the same thing, but what? They come from the primitive neural structures, but dig deeper and you'll know that it's difficult to explain why there are incidence of cervical ribs and sometimes of rib vertebral anomalies is more common in complex congenital heart disease, not in ASD, in complex congenital heart disease. What I mean is that you have to get fascinated. If you say this synovial osteochondromatosis, I am done, finished, I know the diagnosis is wrong. How does it form? Homework. All of you read. How does in osteoarthritis of the knee joint, forget this, that you get so-called loose bodies, and what are those loose bodies? Why do they form? And what is the role of the synovial fluid in making those bodies? Okay, what would you do next? What did you do next? Is there any other differential diagnosis? I would think not. If you ask somebody and asked me, I said, "This is." I will bet my last buck that this is synovial chondromatosis. What will you do next?
MRI to confirm
Okay, you will do an MRI. MRI will confirm the diagnosis.
to see.
So, how many of you feel that an MRI is required to confirm the diagnosis?
Not to confirm the diagnosis.
No, wait a minute. You said no. What about the others? Would you do an MR or will you do a CT? Why? To see bone.
To see the marrow.
No.
If the patient is in pain, to see the marrow edema, whether the
Okay,
chondromatosis would
do
like
one
the
thing. No,
left
next
side.
time you get a boil on the skin. Yeah, do an MR. Yeah, I want to see the MR of a boil on the skin and show it to people who never know that it's a boil. They will call it all sorts of things. Now, marrow edema, a big deal is made out of it. There will be edema, no, any damn thing there will be marrow edema. If you have a fracture of the bone and do an MR, the marrow is full of edema only. What is the big deal? So why would you do an MR? So to know why you do an MR, you should know the treatment of it. There was a time when the MR was not available, such patients were being operated. So go to the surgeon who's going to operate this and ask him an MR. You ask for an MR, why do you want an MR? Okay, and tell him that when you operate, tell your teacher to request him to allow you to attend the surgery. You have to attend the surgery if this patient has not yet been operated. Where is this from? Sorry?
January.
But the patient may still not have been operated, no? So just follow. So once you attend one surgery like this, the whole thing will fall in place for you for a lifetime. You don't have to read books again. You will know more than the examiner. And this is maybe gone. But in a hospital like this, you have a gold mine of information. You can sit in this room in darkness and never get wiser. On the other hand, you see one surgery and you have pathology also. You have postmortems? No, you don't have postmortems. And you have pathology. You have to have radiology pathology meetings. You have no? Only for bone tumors or everything?
We have bone tumors every Thursday.
Okay.
We have provincial hospital.
Okay. And that is the one that has been going on for ages,
Yeah.
no? Yeah. Okay.
And others, I think mammo happens once a month.
Okay, so whenever you have an opportunity to learn pathology or attend surgery, never bypass it. One day if you have to work harder, it doesn't matter. So, you have no idea how it looks like at surgery. And you'll be shocked to see how it looks like at surgery. I've seen only once in the knee joint, right? Because it was so full of synovial osteochondromatosis that I saw the total knee replacement and you'll go aghast at what it looks like inside the joint. Yeah? The only object of my coming here is to make you feel inspired about what you do as a radiologist, right? Not to teach you radiology, but you learn from books. So, I will not discuss MR because I don't know more than you. So I will not discuss the MR, but you have to tell me why an MR is required, what additional information this MR gives, and how it helps in the management of the patient. You don't need an MR to make a diagnosis here, unlike pigmented villonodular synovitis. That's a different ball game. But for this you don't require. But synovial cell sarcoma you may require. But for this you don't need an MR, but an MR is still asked for. Why is it asked for? The answer comes from the referring surgeon. Right? You can read books and you will never know. So you have to cross the border, go to the opposite side and keep asking them why? Yeah? And once you ask, you have learned it for a lifetime. It's a simple thing. You cross the border once and you know what Pakistan looks like. But you have to cross the border. Yeah? Okay, I think we'll stop now. I have to go early today.